I'm jumping ahead to season 6, where House actually confronts his use, perhaps overuse, of his Vicodin. But for this episode, I need some help from my friend, Dr. Eric Bender. Welcome to the show.
My name is Dr. Eric Bender. I'm a psychiatrist. I specialize in psychotherapy. I see children, teenagers, adults, and couples, and I do a lot of work with media, and I'm really excited to be here today.
Huge thanks to Grammarly for sponsoring this video. Patients in the space where they're using pain medications, are they counseled appropriately, you think, in terms of what the risks are of these medications?
I think these days, yes. In the beginning, not so much. That idea of, let's double your dose if you're having more pain. There were a lot of things.
Like we have to get to zero pain.
Yes.
Oftentimes was an unrealistic and perhaps harmful goal.
Yes, and I think medication, I even say this to patients with depression, anxiety, other mental health issues, medication is a part of treatment. It's rarely the only thing. So what else do you need in your life that helps decrease pain? It's not always pharmaceutical.
That's always a good flag, because when I ask patients about timing of their pain, some will say, well, I have it more at this time in the morning or at night, or when I'm doing this activity. And that's true, I want that info. But a big part of it is, are you having it on weekends when you're not working? Are you not having it during weekdays when you're away from your stressful family? And those kinds of hints will allow me to tailor the questioning in a different way to better understand what's driving the pain. Because if someone has an anatomical injury, it's not gonna pick and choose days of the week where it's gonna present itself.
Yeah, and I think you're referring to something we call somatic symptoms too. A lot of people feel stress and anxiety as pain. It's not me saying your pain is not real. That's how you experience some of these other emotional things as well, and you have a chronic pain. Because if he's taking anything for detox still, he'd want to take that. And he's not behaving in ways that suggest he would need something, unless maybe it's an antidepressant medication, which can decrease aggression sometimes.
Do they check that you take the medicine usually?
I was gonna add, so if there is a patient that you suspect is cheeking, you can do a check.
Is that what it's called, cheeking?
Cheeking,
Oh,
yeah.
I've never heard that.
Yeah, cheeking. If you think somebody's cheeking, you can ask to examine their mouth. Lift up your tongue, stick it out, please, say ah. So not because we're punishing you, but we really think this is what's good for you.
You're not having any side effects.
We do this in a primary care outpatient setting, is we do have controlled substances agreements. So if a patient is coming in and we're the primary prescriber for a controlled substance, we will create an agreement where we will decide how often refills are done, what would happen if medications are lost, for what period of time they're prescribed, how many number of refills, if there is ever a need for urine drug testing, how will it happen, so that there are no surprises and it doesn't feel like anyone's attacked, because this is just a universal policy.
Exactly, and when I have had urine toxes for patients, for medications, it's typically because an organization requires it. So if I see professional athletes, they're gonna have a urine tox not only for illicit substances, but if a professional athlete is taking a stimulant medication for ADHD, then they might have a urine test where that shows up, and it shows the professional organization they are taking their medication as they're supposed to.
If someone has a delusion in a scenario like this, where he says, call me by this name, I'm a superhero, I can do all these things, how do you approach that while being respectful and trying to, I guess, initiate a potential challenge so that the person can feel more in touch with reality?
What I would do is I would call him by his name. I would not call him out of a group. I would not put him on public display and try to humiliate him in any way. In individual sessions, I would probably try to say, tell me more about this. When did you realize this was your identity? How did you first understand this? You work with people where they are, especially in a long-term care facility where you're not limited to a few days or weeks. This could be weeks, could be months, could be longer. Which again is a good thing to stand up for, whether House is standing up for the patient or just proving a point. But I do think more than the war between meds and therapy is the war between this doctor and House and this patient.
Back to House in just a second, but first I want to tell you about Grammarly. It's an AI writing partner that helps professionals with all their writing needs with high quality and personalization. So it sounds like you, not AI. If you've been watching my channel for a while, you probably noticed I'm uploading a lot more podcasts lately. While these conversations have been truly satisfying, it has forced me to write a lot of scripted intros for each guest. This is where Grammarly's AI tools have been super helpful. I can brainstorm with the AI chat on the perfect way to intro each guest. Grammarly can provide me with tons of suggestions, particularly with the Humanizer tool that can really make sure my writing doesn't feel too robotic. And of course, I'm most concerned with the audience's response to my writing, which is why I've become such a big fan of readers' reactions, which predicts questions and confusion you might have based on my current draft. Grammarly then suggests revisions to improve clarity and get me to a final final draft sooner. Level up your productivity and get Grammarly today. You could use my link for 20% off pro. Well, the test is just asking you subjectively how you feel. Are you fooling yourself by doing it?
Yeah. He's trying to manipulate the system. He's doing anything he can to get the letter. Get out.
The hardest part for me as a primary care doctor with mental health conditions is what to do when a patient is unmotivated or perhaps doesn't want help, and this kind of falling into that scenario. What can one do as a provider in scenarios like that?
And I think they're actually showing, I think Dr. Nolan is doing, he's talking to him, being, do you realize any of this? So you're saying you are better because you've learned how to lie and manipulate. So you try to help somebody see the patterns of their behavior and how it's affecting them. Is it serving them well? Is it not serving them well? What does serving them well mean? And at other points, if this were not a medical licensing issue,
do directors just say, I'm done with you?
I think with somebody very narcissistic like that, there are people that will say, I'm done. Like, you've caused so much danger, so much havoc. There are other people you can go see. You should do that. Legally, there are some steps you should take.
Like a 30-day period.
Give them a certain amount of time, give them names, all that kind of thing. But at this point, this guy knows exactly what he's doing, and the attendings, like, he's not a danger. He's not gonna find some harm from being cut loose from my practice. Just let him go.
Yeah.
Don't. I need help. I've had a billion things.
Doctor is becoming demonstrating a high level of empathy here. Do you ever develop compassion fatigue?
I don't, but what fatigues me, I really want to focus on my patients in the 50 minutes, and I see back-to-back patients. I get tired because I'm just trying to focus, and it's very individualized. I'm not doing a generic thing with everybody. It just doesn't work that way. What happens for me at the end of the day is not compassion fatigue, but just listening fatigue. At the end of the day, saving enough for my family to be able to say what was going on in their day and all that. Because what will happen is they'll say, how was your day? I'm like, it was fine. And that's it.
Yeah.
I want you to trust people. Try.
That is a big issue I see in people, particularly people with a lot of trauma, is they have a really hard time trusting people with what's called complex PTSD. It takes a lot longer than just a couple days to be like, oh yeah, try. Because there's a reason that people don't trust people. And sometimes it takes me a long time with patients to get to that point of them realizing they don't do that. And I'll have to comment on what it's like to relate to them. So this is a very brief way of introducing the concept, but what would unfold in therapy would be a little bit different.
Just open up. Trust.
That's like saying just chill out to someone who's having a panic attack.
Calm down. Yeah. Don't worry about it. Like that's a little egregious, but I get what he's trying to do. It just would look differently in real life.
Doing this type of therapy, there are so many moral, legal, cultural things that need to be taken into consideration. How does one balance what is right to do? Like, he's like, the right thing to do would be to apologize, or whatever statement he's making there.
I learned that by observing the patient and understanding them and having them tell me about their family culture and what they think. I learned about their choices, and I learned that along the way. I wouldn't say it's the right thing to do to a patient. I would say, what would it be like if you considered apologizing? How would that feel? If they're like, well, that would be wrong, or that would be right, I'll say, what's right about it? What's wrong about it?
So you want them to be more reflective?
I want, yes, it's so much better to have it come from them than for me to